Hello, everyone. Thank you so much for joining us. Welcome to the Power of Mentorship in Eating Disorder Treatment. My name is Kristen Portland. I'm the Executive Director of ANID. Just a couple quick housekeeping things before I pass it over and let these other wonderful people introduce themselves to you. This webinar is going to run for about an hour. We will be sending out the recording and slides afterwards. Everyone, please feel free to drop in questions throughout. We'll answer some in real time as it makes sense, but we will have a designated Q&A at the end as well. So we're going to be talking a lot about mentorship. EQIP does some incredible things with mentorship in the course of their treatment. And if you aren't already familiar, ANID has a mentorship program as well. We'll be touching on a little bit of that in the course of today, and you'll be getting resources sent out following so you can learn more about anything we talk about. If you have any questions, we are here. And with that, we can jump right to it. And I'm going to pass it over to the amazing Maris to get us started.
Oh, thank you. Let me share my screen. And the obligatory, can everybody see my screen? Show it up well? Okay. So we're here to talk about, as Kristen said, the power of mentorship in eating disorder treatment. These are the folks who will be chatting with you today. We'll quickly introduce ourselves over here on the next slide. While I'm talking, I'll just keep talking and quickly say I'm Maris Degener. I'm the Director of Peer Mentorship here at EQIP. I recovered from anorexia nervosa as a young teenager, which led to me feeling really passionate about wanting to talk more about my story and utilize lived experience to support others through their own mental health challenges or eating disorder recoveries. And I'll pass it to you, JD.
Thanks, Maris. So I was formerly an educator and came into this world when my own daughter had anorexia at the age of 17. And we were really lucky to get evidence-based care and get a lot of really wonderful advice. And that just made me really passionate about sharing that with other folks. And so she's doing very well today. And I'm just so excited to do this work at EQIP with having family mentors be part of teams as well, alongside the peer mentors, and really bridging theory and practice. And Jen.
Hi, I'm Jennifer Gerain. I'm a child, adolescent, and adult psychiatrist. I've been working in eating disorders for my entire career before coming to EQIP about a year and a half ago, where I took on the position of VP of Medical Care. I was actually at Stanford on the Medical Stabilization Unit for about a decade. And I'm also a member of ACAP, which is our Academy of Child and Adolescent Psychiatry, and a fellow in the Academy for Eating Disorders. And we're super excited to be with you today. All right, our objectives for today, we are going to explain the importance of and describe the evidence for peer support in improving health outcomes. We'll be identifying key characteristics of peer and family mentors and how they can play a role in eating disorder treatment. And we will describe how to include mentors in clinical practice, as well as recognize the importance of multidisciplinary teams that include those with lived experience. A little bit of background. So why does mentor support matter? I think this is one of the things that really drew me to working with EQIP. We know that peer support has been shown to be beneficial for improving health outcomes in numerous studies. It's a strategy that's been widely used to improve the physical, emotional, and psychological health of individuals and also promote self-management across diverse diseases and population groups. There was a recent systematic review that showed 83% of studies, in a systematic review, 83% of the studies that were looked at reported significant benefits of peer support in promoting behavior change to support chronic disease management. And that's across diagnoses, not just in the eating disorders field. By extension, we have data and evidence to support that support our contention that peer mentorship is effective in eating disorder treatment. So at EQIP in particular, our peer mentors are individuals who have successfully recovered from an eating disorder. They have about 2 years of solid recovery under their belts. And we know that peer mentorship can lead to improvements in body dissatisfaction, mood, and eating disorder behaviors compared to the other types of social support, or no additional support at all. We also know that peer mentorship improves quality of life and helps eating disorder patients attend appointments with treatment providers. And just some examples of peer and family support in action. As I said, this is something that's been of interest across different chronic diseases in the medical field, not just something that's unique to eating disorder treatment. So in folks with inflammatory bowel disease, the Crohn's and Colitis Foundation has a group called the Power of Two. The American Diabetes Foundation is the Association of Diabetes Care and Educational Specialists. NAMI, which is the National Alliance of the Mentally Ill, has peer-to-peer and family-to-family support available. And the Cystic Fibrosis Foundation offers the CF Peer Connect program, which allows patients and family members to be able to seek out additional support and connection. Just to give a little context about the model that we use at EQUIP, we are based on family-based treatment, but there are some enhancements that have been added to it to make sure that we're able to really provide the care that families have told us are the care that is important to them. I think the feedback that we get pretty consistently is that we know that FBT has the highest amount of data to support its use. And at the same time, we know that there is much more that is needed in terms of support. And our families have told us about the types of resources that they find most helpful. So we provide everyone who comes to us with a dedicated virtual 5 to 6 person care team. That includes a therapist who's been specially trained in eating disorders and in family-based treatment, a medical provider that may be a physician, a nurse practitioner, a physician assistant. And depending on the particular situation, if there is a need for psychiatric medications, there may be a psychiatrist or a psychiatric nurse practitioner involved in care. Our dietitians are also eating disorder specialists with particular background in family-based treatment. And then, as I've said before, my favorite part of the EQUIP team is actually the lived experience component. We incorporate a peer mentor who works with the patients individually and a family mentor who's a parent who's helped a child recover from an eating disorder. The mentors go through a pretty extensive training regimen that we'll talk about in a little bit more detail. But I think the other kind of key parts of EQUIP treatment are that we have flexibility in our sessions. In terms of scheduling, we're able to kind of dial up or down the intensity and cadence of those appointments based on what's needed in any given clinical situation. We're also able to message asynchronously with carers and patients between sessions. And families are allowed unlimited skills groups, and those are some that are unique to patients, and then also those that are particularly curated for families and carers. And I believe, am I passing this one on, or is this one still mine, Maris?
I'm happy to take it, Jen. I can chat a little bit about.
Sorry, I just lost count of where I am, and so I didn't want to step on toes.
No worries. You want to go for it?
Sure. The mentorship part, I think, has really been integral in helping people stay in treatment. So it's one thing for them to hear from licensed clinicians that here are all the reasons that recovery is important, and here are the reasons we're concerned about these behaviors. And it always kind of reminds me of the Charlie Brown teacher that is kind of like wah, 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 wah in the background. There's something that's so much more powerful when people hear from someone who has been through it, someone who's lived through this experience and who is able to say, you know what, this is really hard, and there are so many things about it that are irritating. And Recovery is possible, and it's so worth it to get back to that life worth living. We really make an effort to try to match our patients and families with mentors who have shared lived experience to make sure that treatment is a safe space. So that may be in a diversity of background or particular experiences, unique interests or other characteristics. We know that representation is important, so we've really made an effort to recruit a provider community that provides diversity of experience to the patients that we serve. And now I will pass it along.
Thank you so much. Just to talk a little bit about my story and what has given me this sense of, hopefulness around bringing lived experience into eating disorder treatment. As I mentioned before, I was diagnosed with an eating disorder when I was a young teenager, so my freshman year of high school. And initially, my parents just started to become concerned about drastic changes in my eating habits and increased exercise. And they did not have much education on eating disorders. They kind of knew oftentimes the stereotypes or myths that make their way into popular culture or media. So they felt very lost on how to address the issues that they saw. They ended up bringing me to my general physician, who referred me to a more specialized eating disorder provider, who recommended hospitalization at that point to address the physical concerns that had come up. And luckily, my parents at that point received education on how to support my recovery by taking on the responsibility of refeeding me, promoting weight restoration. And I think it's important to highlight here that this was all before I felt fully ready to recover. Because of that, I felt very alone in this process. It wasn't me raising my hand saying, hey, I'm ready to recover. I'm ready to take this journey on. And I just didn't know anybody else who was in that position. I didn't have anybody who could role model recovery for me or relate to that challenge of having to start before you felt ready. And it was a pretty isolating experience. Later on, as I made progress in my own recovery, I started talking a bit more openly about it, talking a bit more to peers at school, and then eventually a bit more publicly. And I was really just shocked at how common eating disorders are. It was like all these people were coming out of the woodwork to say that they themselves had been through that experience, or their child or a loved one or friend. And I just really craved hearing more stories of hope and full recovery, and couldn't help but wonder, wow, what if I had heard all of these stories before, when I felt most alone and most needed them? So to tell you a little bit more about the peer mentor role in particular, our mentors are skillful. So rooted in both lived experiences and training, mentors are prepared to support patients experiencing challenges such as suicidal ideation or self-harm. And they're also prepared to handle these really difficult topics while upholding professional expectations around confidentiality and boundary setting. Mentors can also elevate connections. So as Jen mentioned before, we really take care to assign mentors based on connections to the identities and experiences of both the patient and their family. This might include things like a shared language or culture, diagnosis, or membership to a community such as the LGBTQIA+ community. Our mentors are also team players. So at Equip, as our peer mentors are able to be a part of the full clinical team, mentors can exercise clinical judgment and provide information and perspectives that will enhance patient experiences and outcomes. And our mentors are resilient. They're very skilled at recognizing boundaries and limits, and with proper support and supervision, can sustain their own recovery while being in the field. So we have a little video to show you. This is a little role play of what a peer mentor session might look like, just a quick snippet. I am doing my best to play a bit of a reluctant patient in this clip, so you'll have to bear with me and let me know if the audio comes through okay.
And I'm definitely interested to hear more about this birthday party. I know Adriana's been a really good friend for you, so I'm interested to kind of hear more about what's going on with that. But before we get into that, I know you mentioned the weight gain feeling like a tough point, and so I wanted to see like what's been on your mind recently with that. Like what feels really tough about it for you?
Well, I feel like, I know we talked about this a few weeks ago. We talked about social media and how I was following a lot of accounts that were kind of like triggering or whatever. And so I unfollowed a lot of those, and I started following a lot of those like body positive accounts you told me about. And like I know it's like I shouldn't care about gaining weight. And like I read all this stuff, like I still don't feel good about it. And I still wish I wasn't gaining weight. And so like, I think especially like getting ready to go to this party and stuff, like I don't know what I'm gonna wear. And I'm just like, it feels like it's never gonna stop. Like I'm never gonna have to stop gaining weight.
Yeah. Sounds like it's feeling really overwhelming and really tough right now. And I totally hear that. I remember feeling that way and having so much fear around gaining weight and what that would look like for your life and how that impacts you. And I'm curious for you, like I know we've talked about this in our last sessions of how there's maybe some other things tied into that fear of weight gain. Can we kind of explore that a little bit more?
Yeah.
Yeah, so I'm going to ask you a question and then I'm going to say, so what? And then I want you to respond with what comes to mind for you. So let's say you gain weight. So what? What happens?
I'll feel bad about my body.
Okay. So let's say you feel bad about your body. So what? What happens then?
I'll feel like less confident.
Okay. And you feel less confident too. What happens then? So what?
Well, it'll just be really hard to like enjoy things or enjoy doing the things I want to do.
Mm-hmm. Yeah. So it sounds like there's a lot of other things that are like really tied to that fear of weight gain and confidence and feeling like tough about your body and also like just not enjoying the things around you. I'm curious, are there any ways that you can kind of support those things without it being tied to the fear of weight gain anymore? Like, are there any ways that you could try to enjoy the things around you or focus on those things instead of how your body looks or the weight you're gaining?
Well, I know you've talked about like doing things I like, even if I still feel bad about my body.
Yeah.
And like kind of breaking the habit I have around avoiding it. If I'm having like a bad day feeling about my body.
Yeah. Makes me think a lot about the birthday party coming up. Are they doing any fun activities that you might enjoy there?
Well, like I think I told you, like my friend's really into like ceramics and stuff. And so she's gonna bring a bunch of her pottery and we're gonna like paint it.
Oh, that's awesome. I know you love painting. So I'm curious, is that something that maybe if you're going there and you're feeling kind of nervous about weight gain in general and also feeling uncomfortable with thinking about that or thinking about your body, is there a way to focus on that art that you're creating or that time with your friend?
Yeah, I mean, I guess I could try to just like, if I'm thinking about a lot, try to like do that distraction thing and just do the art stuff.
Yeah, I love the idea of just doing it. That's amazing. And I think sometimes when we're in those moments, we can kind of forget to remind ourselves of that and we can get really caught up in feeling super distressed and overwhelmed. And I'm curious, are there any ways that you can like really remind yourself or some tangible ways to remind yourself of kind of this idea going in?
I mean, I know we've done like the alarm thing before. That was helpful with like the body checking thing.
Yeah. Do you want to grab your phone real quick and kind of set some up for this weekend?
Yeah.
What is something you think you could write down to kind of remind you of this goal?
I know when we were working on body checking, you put those like cheesy things on.
Yeah.
The like cheesy, like you're better than your body stuff or more than your body stuff.
Yeah. How does that feel for this?
And like I guess it worked before.
Yeah, let's try it again. That sounds great. How often do you want to do this?
I mean, I think I'm gonna be there for a few hours.
Mm-hmm.
So like if it starts at 5, I guess I could do it at like maybe like 6 and 8 or something.
I love that. I think the idea of having it like kind of come in at multiple times can be super helpful for your brain, like we've talked about, of having multiple things to remember it by. That's awesome.
So thank you for bearing with my untrained acting skills. I think I was trying to tap into how I might have shown up, a bit earlier in my recovery, and a special thanks to Allie for role modeling that our peer mentors can really practice meeting patients where they are, even if they're maybe not, like I said, super eager at the beginning of their journeys, or maybe struggling with certain challenges that can come up. We're able to slowly nudge them along and give them practical ways to navigate those challenges. So that I'll pass it to you, JD.
Thank you. So our story in our family is that in 2011, my daughter, who was a senior in high school at 17, she and her friends were done with their high school sport and decided to undertake a healthy eating makeover. So they did not put on the freshman 15. I think it's really important to say that she didn't really have significant body image or self-esteem issues going into this. So I think there's probably not anybody on a high school campus that doesn't have some of that, because that's the culture that we live in. But certainly compared to her peer group and things like that, she actually was probably not the one you would think might develop an eating disorder. And this new eating plan began sensibly, but it really rapidly deteriorated. And within 4 months, she was in the emergency department with some medical things going on, sort of all of that. She also had anosognosia, or lack of insight, and she was clearly and accurately reporting medical symptoms. So she also was baffled by a lot of what was happening to her, the dizziness, the inability to eat, all of that sort of stuff. Dairy products and anything containing gluten had gone by the wayside. So we were talking to the pediatrician, the gastroenterologist, doing all those tests to rule out things. We were then very lucky that we ended up at some place that does provide evidence-based care. And there's not a single one of the stories that I've ever heard in a decade of being in this world where a recovery was easy. And hers was certainly no different. However, it was possible. She achieved it. And that's really what we, as family mentors, want to bring that same sort of hope, as Maris was talking about, being able to observe people who actually are in recovery. And so being able to see families who've been through eating disorder recovery with their child, and particularly in the FBT format, people who've been through FBT, because it can be it's a hard process for everyone. And it can feel for families like maybe we're going to ruin relationships in the long term. And that's not what we see at Equip. That's not what I've experienced in a decade of doing that. And interestingly, today my daughter is almost through her master's to become a therapist. So she'd like to work with eating disorder patients. First, she's going to become a mom in a week. So all exciting stuff, and all really came from this ability to really beat this, have support in multifamily sessions from other parents, and really seeing the power of that. So at Equip, our family mentors are really a bridge from theory to practice. So we're helping families find ways, meeting them where they are, to effectively implement the clinical advice at their kitchen table, and generally over tremendous resistance from their loved one's eating disorder. So the emotional support, which really comes out of having this visceral connection, that we know that we can understand each other's fear, all of that sort of stuff, because those are just very common feelings among all families. One of the things I think is incredibly helpful is to normalize symptoms. So resistance to care is normal, all of that sort of thing. And one thing I see, I do a lot of multifamily groups, and when we're in a group and someone comes in new, they often believe sort of all of these things are very singular to their child, that they are about their child versus the eating disorder. And when you see people sort of go like, oh, if 15 different people are seeing this behavior or having this thing happen, oh, it's a little bit more believable that it's the eating disorder. Because one thing about most parents is we really want to be compassionate and collaborative and everything with our children. So it can feel very, very just unnatural and different to us to sort of take over the reins in the ways that FBT requires. I think the logistical support is really huge. So we use our own experiences, experiences of our own, being part of support communities, The training, we offer phenomenal training at Equip for all our providers. So we use a lot of motivational inquiry to be able to support families in collaboration. And then just again, all of that logistical support. I mean, one of the things I think that we often will say as family mentors is we'll support people to take a lot of things off their plate, or what we call recognizing your glass balls and your rubber balls, and the things that you have to take care of now, and the things we're sort of giving you permission to put aside is really helpful. Then the clinical support. Working part of these 5 to 6 member teams is just such an amazing experience for everyone. And we can bring that perspective and experience that we have, and also what we're hearing from our families, to the full clinical team, just as the peer mentors do. And that support really drives everybody in sort of a continuous quality sort of way. We're all always learning from each other, and we're all helping each other improve our practice. And we really, as family mentors, can really suss out how we anchor these things in sort of people's reality in their lives. And again, those groups, we have lots of family mentor groups. We have an over 18 group. We have a men's specific group. We have sibling support groups, which I think is hugely important, that are, by elementary, middle school, high school, and college. Those are over 18. So those are all really helpful. So we have a role play here as well. Oh, we have no phone.
How am I able to better help support you today? Is there any challenges you are having currently?
Yeah, honestly, there's a really big challenge, and it's actually really hard for me to talk about or admit, just because I never wanted to get divorced, and I certainly didn't want to be in the position of considering that I might have enough money to buy the food to do this with my son. Everybody's been so great, and it absolutely sounds like exactly what he needs. And then I hear about like the hypermetabolism and how much food it is. And honestly, I'm just kind of in a panic of how am I going to afford this food?
Yeah, and I just want to start off by saying, thank you for sharing that. I can hear how difficult it is for you. I was also a single mother, and I also had a similar issue, so I can definitely hear that that is something that's been really challenging. And so I do want to share that the Family Navigator will be able to assist with helping with like SNAP benefits, as well as our registered dietitian. Our dietary team has experience working with families who you are able to utilize SNAP benefits. And they will help you to learn how to achieve the high caloric needs at an affordable cost. So I hope hearing that, helps you.
That does help you. I really appreciate you sharing that you've been through this too. And so did you feel, because I know you said, you had a daughter, not a son, but like, you think I can do this? You think I'll be able to do this?
Absolutely. Is it going to be easy? No, there's going to be some challenges that we are going to face, but together, with myself, with your Family Navigator, with the treatment team, we will be able to help guide and support you through all of this for both you and your son.
So that was one of our amazing mentors, Chita Gastelam, who will be rolling out a Spanish language public group alongside the one she leads internally. So as we've talked about several times, it's really important for us to have matches and really meet people where they are. And we definitely consider that language piece of things as well. And Chita is absolutely wonderful.
One of the things that people often ask me about is, how is it having mentors on the team? Do you feel like you have to worry about their credentials, their ongoing supervision? And those are great questions. I can honestly say that I love the mentorship component, and I find it to be one of my very favorite things about working on these treatment teams. Cost is really not an issue. There's time saved in my day-to-day. So yes, I'm able to provide the typical high quality care I would normally provide. And I'm able to kind of send the patient and the carers back to their mentors for additional discussion about things. So a parent might say, I just, I really worry that my child's never going to recover. Can you reassure me on that? So I can talk to the what we know from a data perspective, and I can also speak to my experience as a clinician. But I think what is most meaningful is actually being able to send them back to people who have the lived experience and are able to reflect on the things that are tough and the things that are worth it, and kind of what the normal trajectory looks like. It also means that our medical visits can be more focused, right? So again, I am not kind of feeling as though I have to do all of the tasks on the team. So I have a dietitian that can reinforce messaging around nutrition. The therapist is the one who is really at the helm of the ship when it comes to the specifics of family-based treatment. And the parent and patient support is something that I'm able to work with collaboratively with our mentors who have that lived experience perspective. I also find that the teams are more engaged. Again, mentorship is different from individual therapy. There's a lot of skills building that happens. And I think that, again, this feeling that we have this shared experience, and we may not have had exactly the same backgrounds or exactly the same story, but you know what I'm talking about. And it just feels really powerful and impactful to have that incorporated on the team. Families feel more supported. We oftentimes say, we've got the licensed clinicians. That's one aspect of knowledge to impart. Lived experience is equally important and impactful. And I think together with our patients and our families that we're treating, we make a really good team. We have lots of experience and expertise about eating disorders, but also about particular individuals and families who are part of the process. A lot of times people will come back and say, FBT is great. I understand the philosophy and where we're coming from. And this is just so hard on my child. I would really like for there to be more focus on individual therapy. I feel like they're not getting kind of the mental support they need to get through this highly emotional time. Again, the peer mentors, they're not offering individual therapy, but the skills that they're able to offer, they are able to talk about things like developing cope ahead plans, talking about body image, offering support for, here's how I think about the fact that I had to miss, being part of my sport for a while, those sorts of things. And as we've said previously, we really try to match mentor attributes to the patient and family, which again, I think comes back to this feeling seen, feeling heard, and feeling as though those shared characteristics are being taken into account as we plan treatment moving forward. Training, I think this is something that always comes up. People wonder, are these volunteers, what does this look like? And I always like to just be really explicit that, these are employees who go through a really robust training experience. They get over 90 hours of training on 43 different topics. We're continuously going back and making sure that we are refining and building upon the things that we're learning throughout our experience with the model. And so this includes learning about eating disorders in general, myth busting some of the unfortunate stereotypes that are out there, making sure people are up to speed with best practices for providing telehealth. We talk a lot about social and cultural considerations, and it's going to be impossible to match someone 100% on all factors. So how do we kind of take a step back and say, I may not share your cultural background, and I know that this is important. Let's talk about how this comes up for you throughout the course of treatment. They collaborate with the team. We focus on the behavioral framework and really focus a lot on imparting the tools and skills that are necessary to share with patients. We also talk about responsible self-disclosure, right? So we have to make sure that people recognize that my experience is not going to necessarily be everyone else's experience. And I have to be thoughtful about what I share and how I choose to share it so that it doesn't inadvertently kind of derail treatment. We also need to be mindful of safety concerns. So if a patient shares something that is concerning in a session, how do we loop in the appropriate members of the treatment team to make sure that we are taking the situation seriously and getting the person the care that they need? We also are working towards certification with all of our mentors to really highlight and recognize the expertise that they bring to the treatment teams. It also allows us to have some standardization, make sure that we're providing quality care across the board. And this ongoing supervision and training is really important for continued personal and professional support from a variety of lenses. So we're reviewing recorded sessions for quality and fidelity to the model. We're also providing group supervision and individual one-to-one supervision to talk about the things that come up in the course of treatment, how someone handled something, what they wish they had known, and how they might do it differently the next time. And also give an opportunity for processing and support groups. A little bit in terms of measures and outcomes, we really pride ourselves on being a data-driven organization. So this is something that we're constantly looking at. Patient progress is continually measured to achieve the best outcomes. So we use validated measures that are pushed to the patients and families on a regular basis. For patients, we're looking at the PHQ-9 for depression, the GAD-7 for anxiety, and we use the eating disorder examination self-questionnaire for eating disorder symptoms. We're also looking at carers. And so the patient versus ED scale is used to assess caregiver self-efficacy, and caregiver burden is assessed using the burden assessment scale. And we also want to be sure that we're providing safe care. And so we're routinely looking at regular weights and vital sign monitoring, which we track in our electronic medical record. And this is monitored closely by the medical providers on our team to make sure that there's no need for any additional medical interventions. And then a little bit of a representation of what we're seeing. Patients and families are seeing meaningful improvement in multiple domains. So 64% of patients report reductions in eating disorder symptoms in the first 8 weeks of treatment. 73% of caregivers report improved confidence to care for their child after 8 weeks, which is, I think, really significant given how challenging this can be, especially in those early weeks. And 54% of families report a decrease in caregiver burden after 8 weeks. So I think this is highlighted quite nicely in the graph that you see on the slide here. And I will pass it along for a case study.
Thanks. Yeah, we're excited to bring some life into this with some examples and stories. Obviously, we're all passionate about the storytelling element of lived experience here. And first, we actually have a short clip from an ADAD mentor, Kevin Jarvis, that I will hit play on.
Hi, my name is Kevin. My pronouns are they, them, and I have been involved with the Mentorship program for about half a year now. And previous to being a mentor, I was a mentee in 2020. The Mentorship program has been really important to my own recovery journey in a lot of ways. First important way was that my mentor is still somebody that I am in contact with and somebody I consider a really good friend. They're queer and disabled, which are both identities that I hold, and they're really important. And usually when you enter eating disorder spaces, your providers probably aren't going to hold these identities that are really important. And it's nice to have somebody that can relate to you and not just tell you to keep going and keep trucking, which leads to the other thing of usually your providers only have these strict times that you're allowed to talk to them. And it's really nice to be able to have somebody that I can talk to at any time, and having like the same views about like what recovery looks like to us as like actual people versus what it looks like in like a treatment center or professionals who have never been through it. And now that I'm in a spot in my recovery where I can help others, it's been really important to me to be able to give back to my queer community, especially. So being able to mentor a queer person now and teach them things that I've learned, like about harm reduction and about recovery and how that doesn't have to look, about what it looks like in eating disorder treatment and body neutrality and like all these important things that were really crucial to me that I didn't learn in that eating disorder center. I now get to teach somebody else in hopes that it just keeps happening and happening until community care is just like kind of the norm. But yeah, the mentorship program has been really important to me personally and to my mentee, who has already expressed that they want to be a mentor when they're doing better. So yeah, I think the program has helped hundreds and hundreds of people. I think it has so many benefits, and I think it can grow in so many ways, and I'm excited to see where it goes.
I love so many things that Kevin highlighted here, and I think just to select one of them is that idea that our there's this hopefulness that it will continue to be passed on and passed on. So going from being a mentee to then being a mentor, I think it's a really beautiful life cycle that we're starting to see come about more and more. So I love that Kevin highlighted that. So the case study we wanted to dive into for an EQUIP patient, we'll be referring to this patient as Kiara. Of course, you've changed all identifying information just to respect patient privacy, but I think this is a really beautiful story to highlight as an example of how mentorship can be really instrumental for a family. So Kiara is a 16-year-old biracial cisgender female with generalized anxiety and anorexia nervosa restricting type. So Kiara first started to restrict in March 2020. I think many of us see that time frame and aren't necessarily surprised, knowing many folks who started to struggle during the early stages of the pandemic. And initially, Kiara was ambivalent about treatment, and the family had not fully bought into our recommended target weight range. As noted a little bit later on the slide, Kiara and her family were really tied to this image of her being a tiny person, her living in a small body. And it was quite difficult to help the family start to recognize the importance of weight restoration and moving into a higher weight range for Kiara's recovery and health. Kiara and her parents focused initially on individual therapy as necessary. They had tried other treatment approaches and felt very strongly that focusing more on individual therapy sessions for Kiara would be what would kind of move the needle forward in recovery. So it also took some work to help demonstrate the importance of also bringing other family members into treatment and supporting that part of the process. There was also some conflict within the family about where to prioritize energy and time. So there was some concern about things like missing school to focus on eating disorder recovery and treatment. And there was also another added layer of difficulty in that parents were also beginning to initiate a divorce early on in treatment with us. And so we wanted to make sure we were supporting the whole family through that difficult time. The goals of the family in starting treatment were to show their daughter love and support, to be sure that she was always heard by team members, to resolve the eating disorder, and to return to independent eating as soon as possible. Just wanted to highlight the weight restoration graph for Kiara. So really beautifully moving up over time. This was something that was a labor of love of the care team, which we'll get into a little bit on the next slide, but helping the family buy into the weight restoration process was hugely instrumental here. And it was noted that her eating disorder symptoms began to resolve as weight went up. This was no small feat of the family or the provider team.
And I think just commenting from a medical perspective, this is something that comes up quite often in treatment with our patients and families. in general, in our society, there tends to be a lot of weight stigma and fat phobia. And unfortunately, this is something that we see very widely in the medical establishment as well. And so we talk a lot about health at every size and really helping carers kind of recalibrate their thinking around what it means to be healthy with regard to weight and shape concerns. And honestly, I think that this is really some of the most instrumental work that we're doing often with families, especially in the beginning stages of treatment. Sometimes we're asking them to kind of suspend their disbelief and just focus on the renourishment efforts at first. Working toward acceptance of weight restoration goals, I don't think any of us at this point expect that our patients are going to accept the weight range target that we've set, or that they're going to want to weight restore. And I think a lot of times, especially in the beginning, parents may want us to focus on that. We just need to get to a point where he, she, or they are accepting of the range, and then we can push forward. We know, unfortunately, that it doesn't work that way, that we have to push forward first. And then actually, as we get there, and sometimes we may need to go further than we thought, but when we get there, then we start to see the acceptance really start to fall into place. We know that there is a big difference between medical stabilization and full psychological recovery. And I think one of the things that I see happen pretty often in medical clinics is that we get folks to a point where they have stable vital signs. They're no longer on the brink of going back to the medical hospital on a regular basis. Their weight is within an accepted range based on medical society guidelines. And they, if they have a uterus, perhaps their menses have returned or their hormones have gotten into normal range. But just because those physiologic things have improved doesn't mean that they're necessarily where they need to be psychologically. And so that's something that we spend a lot of time focusing on in EQIP treatment. People that I talk with lived experience universally point to being fully weight restored as a key to lasting recovery. And unfortunately, the science and the data is not quite there just yet, but it is something that we're actively working on. And I think this is going to be the key to really pushing the field forward in coming years.
Thank you. I think it's so important to highlight from that perspective, Jen, that maybe the science, the data isn't there, but we hear from the voices of lived experience so often that it's a key critical point. And just to talk a little bit more about Kiara's story here and where that ties in, is that the lived experience perspectives on the team from both the peer mentor and the family mentor were instrumental in shifting the family's thinking around that topic in particular. So talking about full weight restoration and being well enough, utilizing motivational interviewing to support the parents in understanding the risks of not shooting for full weight restoration so that they can make informed decisions about how to support their daughter. I know this required a lot of effort from the family mentor on the team in particular to help shift that thinking just slowly and steadily over time. And also using the peer mentor on the team with Kiara's permission to educate dad in particular on what partial recovery feels like and looks like, so that they were able to hear firsthand what could be maybe different in Kiara's story moving forward.
Kiara's doing very, very well today. So I think that's really an important thing. And the family's been able to navigate a lot of things with the support of their team. So we want to talk a little bit about some recommendations if you want to institute a peer mentor or some sort of mentoring program. So sort of whatever your treatment setting is, it is really important to access or develop yourself a training program with that all important ongoing supervision and support for mentors. And one of the things that we've noticed here is that both peer and family mentors bring some trauma into this just by nature of what they've gone through. And so that's a really important piece of our how our clinicians support our mentors as well, in making sure that everyone stays in a good space in order for themselves and also to help our patients. and then that treatment model for outpatient, pairing patients with peer mentors as a complement to therapy. And so we always want to be really clear, as Jen has spoken about, we are not clinicians, we are not therapists, so we want to have the full range of what can be helpful to any family or patient. And in an inpatient eating disorder treatment model, you can have a family mentor on unit to support families, and I've heard of this happening, and that's really critical. You just think to have someone come in when you're sort of at that really low, terrified moment and be able to say, it's a long, rocky road, and also here we are, the living embodiment of having made it to the other side. And again, look to what other conditions do around this. Substance use is a very common, chronic disease management, all of those sorts of things. That mentorship component is just so critical and shown to be really helpful for folks. So a couple comments about mentorship from a family. Peer mentorship proved to be invaluable to our family. Lisa, our wonderful family mentor, validated me and understood when no one else around me truly did. She also helped us align our direction with FBT as a couple, unifying us in the fight to get our daughter well. And that unification piece is just so important as well. There's just a lot that you have to align on. So having support to do that is really helpful. And she additionally added, my daughter's peer mentor was to help draw my daughter out. She helped her to see from a shared perspective that the hard things can be done. My words to my daughter had value, but the same words from the mentor landed differently. And I think that's just so powerful when we're talking about our kids, our teens, our young adults, anyone who's spent much time with teens. I used to teach high school, right? Their peers are important, and being able to give those messages. And I also want to shout out on this team, because I'm familiar with this story, the peer mentor really had to build a relationship step by step by step. So very much in that model of meeting that person where they were and giving it in small doses in ways that worked to begin to build that really rich relationship that ended up being so important. So we want to acknowledge some folks who were helpful in this. Kevin from ANAD, who did that wonderful clip. Ali Duvall, who was role playing with Maris, and I actually think, Maris, that you're a very good actress. Rosemary Gaslam, or Cheetah, as we call her, who's also an incredible family mentor, and it does wonderful things with some of her families, teaching breathing exercises, meditation, things like that are all part of her portfolio. One of the moms who said, go ahead and share my name, she talks about Equip glowingly quite a lot. So I'm really thankful to Dina Armitrout for those quotes that talk about how this worked in her family. And then to our Equip research and clinical teams, we are very, very, I would say we're lucky to have the clinical and research teams we have, and also it's not lucky because it's by design. But as Jen alluded to, in some of the areas where we don't have research-based consensus on things, part of our mission really is to get to the place we do and use our practice to support that.
And I was clicking and realized that is our last slide. So I think we have a few more minutes left for questions or comments.
Yeah.
Ladies, thank you so much for this amazing presentation. I work with ANAD mentors and mentorship all of the time, and it's fascinating to see how other people do it. And I wonder, how do you respond to the people who still really worry about mentorship as part of the process, who think it could be potentially too much for people in recovery themselves, or that people in recovery aren't reliable? Because there is still pushback from providers when incorporating mentors into especially a clinical treatment team.
I'm happy to take a stab at it, and I would love to hear from both of you as well. I think, Kristen, there's still a lot of progress to be made within the field to view lived experience as, Jamie Nimick, one of our family mentors, often says, experts by experience. I think elevating them as experts is something we're still making progress with. I think it's important to highlight that one of the core values of mentorship is that no two stories are alike. And so for some folks, mentorship might not be a perfect fit for them in their recovery, and that's absolutely okay. I think some folks may find it to be just not how they would like to utilize their lived experience. There's, of course, many other professions within the field they might want to bring it into in a different way. For other folks, including myself, It can actually feel like kind of a healthy sense of accountability. If I'm going to be talking the talk with patients all day long, I better be walking the walk for myself. So for folks, that might be a fit. And I think in general, settings like Equip, where we're able to bring peer mentors and family mentors in as embedded parts of the care team, can actually help prove that they are important parts of this whole experience. It can help refine or tweak, or like JD said, bridge theory and practice in a way that might surprise providers who may have hesitance. But I think a lot of it is having to see it to believe it. But what would you both add, JD and Jen?
I mean, I would say that this is a common concern that I see from providers, and I just keep coming back to the importance of having some training curriculum and ongoing supervision and support. Right. And I think that's true for all of us, licensed clinicians as well. We're constantly checking our deficits to make sure that we're not getting pulled into boundary violations. That's just part of doing this work in general. And so if you don't have the experience of having been through a training program as part of your journey to doing this work, it's just important to have some knowledge about that. So I think that's just the piece that I keep coming back to, but I would second everything that Mara says. And JD, really interested in your thoughts as well.
Yeah, when I hear that, one of the things that comes to mind, in addition to sort of what Maris and Jen have said about how important supervision and all of that sort of stuff is that you'll hear a lot of times people say, oh, you can't do FBT with this age kid, or you can't be FBT if your background was this, or only families with money with one parent who stays home can do FBT. And I have seen people do FBT amazingly from all of these sort of demographics. So one of the things that's a core value for me is that it's not really fair to prejudge what other people can do. So I think it's a matter of, sitting down as we do an interview, sort of figuring out where people are. I'm just blown away. I don't do as many interviews as I used to, but how people bring their honest self to this. People want to do this work for very, so almost altruistic reasons. It is healing for yourself as well, but they really do want to pay it forward, help other people, all of that sort of thing. And so consequently, they're incredibly honest in my experience in their disclosures. And if there's any sort of reason why it's not the appropriate time for them, very sort of amenable to the suggestion that, hey, it seems like maybe you're a little too close to this, why don't you get 6 more months of recovery under your belt, circle back with us, those sorts of things. So everything's a conversation. So I think blanket statements about what people can or can't do are just not my favorite thing.
I love that so much. And JD, I completely agree. Everyone I see and at all of our volunteers, some of whom are here today, so everyone who is watching and is an ANID volunteer, thank you. But there's some incredible people who really are motivated to use their experiences to do good for others now. And all right, we had another question pop up about the 2-year recovery mark. And this is one that ANID has as well. For our mentors, we require people to have at least 2 years of recovery. And for us, we offer our own definition of recovery with the complete understanding that it means different things to different people. And again, we have a conversation and there's more to it than just that mark. But the actual question is, for you guys, does that 2-year recovery mark start when the person goes into treatment or define themselves as recovered?
It's a really good clarifying question. I love that you highlighted, Kristen, that recovery can mean so many different things to so many different people. We don't mark it as entering treatment, but more so in that person identifies as feeling they're in a solid place of recovery, and then kind of a couple years after that, only to give them some more time and space, like JD said, to come in feeling really well prepared for the possible challenges that might come up.
We had another question as well. Since you use an FBT-based model, what is the age range that you are able to accommodate?
We're currently able to serve people between ages 6 and 24. We recognize that there's a lot of need for treatment beyond that age range, and stay tuned. We're actively working to be fully functional in the adult world in 2023.
That's amazing. All right, we'll give it another minute in case anyone throws any other questions in here. And while we do wait, I just want to let everyone know as well that ANID is currently accepting applications for folks who want to be mentor volunteers through our program. We have a training that is a little bit less rigorous than the 90 hours that EQUIP offers, but you will still get a lot of great skills and be matched to a mentee. And if you need support in any other way, all of ANID services are free. Our mentorship program, we have support groups that meet every single week, open to anyone at any stage in recovery. And our helpline also serves as a warm line. So if you ever just need a minute to talk to someone, we have trained volunteers there waiting to connect. And ladies, I just want to say thank you so much for joining us today, putting out this program. I love talking about mentorship. I think it is absolutely incredible. I've seen the benefits in my own life and everyone around me. So getting to highlight that and put it out there, it's really important to me. So thank you.
Thank you for having us. It's our favorite thing to talk about as well.
Yeah. Okay, then everyone, we will be posting this recording a little bit later today and sharing the slides as well. If anyone has any questions, there will be some info in the follow-up email. You can reach out with those and learn a little bit more through the materials there as well. And everyone else, I hope you have a wonderful day. Thank you so much for being here.
Thank you.